practice pain assessment.
Being able to effectively and accurately assess pain is going to be an essential part of no matter which nursing specialty you find yourself in. Pain assessment management is often referred to as that fifth vital sign. And at its core, pain is an unpleasant sensory and emotional experience, either associated with actual or even potential tissue damage. One person cannot judge the perception or meaning of pain of another person. Pain is going to be subjective. Pain is subjective. And the pain level is whatever that patient says that it is. The pain cause and effect. This deals with any cause of reduced perfusion that interrupts the oxygen supplied to tissues and can lead to impaired integrity. Pain reduces mobility, impairs sleep, contributes to loss of appetite. This is especially pertinent when we start talking into our cardiac modules, when we start talking about angina, chest pain, due to that the body unable to keep up with the oxygen demand to the heart. The perception of pain is influenced by cognitive and cultural factors. Everything from previous experiences to pain, current physical and mental status that can also affect that pain perception. Other cognitive factors are the attention people give to the pain, the expectation or anticipation of the pain, and their expression of pain. Also, keep in mind cultural factors are going to play a big role here, in that some cultures are going to be much more willing to verbalize that they are in pain than others. Starting off with our types of pain, pain is categorized in several different ways. First is going to be acute pain. If you bang your finger with a hammer, that is a recent sudden onset, results in tissue damage, and is usually self-limiting, ends when the tissue heals. May cause physiologic signs associated with that pain. On the other hand, is going to be chronic pain. This is continuous, long-lasting pain, and lasting 3, 4, 6 months or longer, may last a lifetime. Good examples of this is going to be things like arthritis. There are things we can do to lessen that pain, lessen that condition, but we can't cure that condition. Other ways we could differentiate between pain is going to be the first is, again, nociceptive pain. That's that pain from tissue damage. Again, we hit our finger with that hammer, often described as aching, throbbing. And it can be further differentiated into types, such as somatic, which is nociceptive pain originating from skin, muscle, bone, versus visceral pain, such as pain from the organs, such as angina and cardiac pain, cholecystitis, inflamed gallbladder, pancreatitis. On the other hand of that is going to be neuropathic pain. And this is going to be pain that originates when there's no necessarily apparent injury. This is pain from nerve damage. This is pain from the nervous system misfiring. And we may not even be able to physically assess why that person's in pain, but their nervous system is sending out signals that they are in pain. A great example of that is going to be diabetic neuropathy, which is going to be very common. The Joint Commission standards assert that patients have a right to appropriate assessment and management of pain, including pain that is assessed in all patients, an initial assessment as well as regular reassessment of that pain, taking into account any personal, spiritual factors that could be at play. Education of all relevant providers in the pain assessment and management, as well as the education of patients and families regarding rules in managing pain, any potential limitations and side effects that the pain treatments could bring as well. Reviewing the A&P, the physiology of pain involves a journey. The transduction from the site of stimulation of peripheral receptors to the spinal cord. Transduction again occurs when you hit your finger with a hammer, and that signal is then sent to the central nervous system, to the spinal cord. It's then transmitted up the spinal cord, where it's sent to the brain for it to be perceived. At which point, the brain will then send its own signal called modulation, bringing your finger back from that painful stimulus. The pain threshold is the point at which a stimulus is perceived at pain. And pain tolerance is the duration or intensity of pain a person will endure before outwardly responding. When assessing pain as well as that present health status, you want to look at things like, do they have any chronic illness? If so, is this causing pain? What medications do they take to deal with their pain? What other adjuvant treatments are they taking to help alleviate and deal with this pain? And if they are taking medications, what and how often? Do they relieve your pain entirely? Do they help only lessen it? Are you allergic to any medications? And what kind of allergic reaction occurs when they do take that medication? Also, make sure that there's consideration about the patient's beliefs about pain. Do they communicate their pain verbally or non verbally? Be aware of any cultural influences, overt pain expression, stoicism, silence. And then assessing the description of the pain. There's a great mnemonic. There's multiple mnemonics out there. I prefer OPQRST. Onset, when did the pain begin? Provocation, is there anything that makes it better or worse? Quality, describing the pain in their own words. Radiating, does the pain radiate anywhere? Severity, on a scale of 1 to 10, how bad is that pain? And then times, how many times in the past has this occurred? For our textbook, they prefer the old carts acronym. Both OPQRST and old carts will get you the same place, so it is your choice which acronym you prefer. The only difference between old carts is that it separates the aggravating and relieving factors, whereas in OPQRST provocation, we're covering does anything make it better or worse. And otherwise, it is completely your decision which acronym to use. Here I've just included in the slides the OPQRST. You will also see OPQRSTU used, and that the U at the end deals with the patient's understanding of their pain. Do they know why they're in pain? Do they understand ways to deal with this pain? Which would be especially important in considerations of chronic issues. P provokes what causes the pain, what makes it better, what makes it worse. Whereas quality, what does the pain feel like? Have the patient describe that pain in their own words. Is it sharp? Is it dull? Is it burning? Is it aching? Does it radiate? Where is the pain? Does it spread anywhere? This is especially going to be important again in things like cholecystitis, inflammation of the gallbladder, which tends to radiate to the right shoulder. It could also be very pertinent in cardiac assessments, which tend to radiate up into the left jaw, into the left shoulder and arm, even into the abdomen sometimes in elderly females. For severity, rating that pain on a scale of 0 to 10. Should the patient be nonverbal, we can then move on to things like the Wong-Baker Faces scale. And time, again, when did it start? Is it constant? Is it intermittent? Has this ever happened before? For onset, when does the pain occur? During activity, before or after eating? Does the pain occur suddenly or does it have a gradual onset? And what do you think is causing that pain? Location. Again, where do you feel the pain? Can you point to the location on the specific location on the body? And duration. How long have you felt that pain? Is it constant, intermittent? How often does it occur? How long does it last? When getting a further picture of the characteristics of this patient's pain, again, have them describe the pain in their own words. Describe any aggravating factors. And also be on the lookout. Have them describe any related symptoms. Everything from heart palpitations, shortness of breath, sweating, rapid or irregular heartbeat. And because again, this pain is stimulating the body's sympathetic nervous system. The body is feeling like it's in danger at a subconscious level, and it's releasing adrenaline to deal with this danger. And that is also now going to give us a host of other symptoms to go along with our pain. And again, looking at how the patient self treats their pain. Beginning again, what medications do you take, what amounts, how often, but also consider alternative methods. Are they using massage, mind and body exercises such as guided imagery, lifestyle changes? And again, how much pain are you experiencing? Are you feeling constant pain throughout the day, or does it come and go? On a scale of 0 to 10, with 0 being no pain and 10 being the worst pain possible, again, have the patient describe the intensity of the pain, the strength, the severity, and at what point on this 0 to 10 scale do you usually want to take your pain medication? Ask the patient about how they respond to the pain. How do you express their pain? What do you fear most about the pain? Is this pain that is coming after eating and it's now having the patient reluctant to eat? Does the pain have any concerns? Do you have any concerns about that pain relief? There's a lot of side effects that can come along with pain medication, even whether it's just hepatic toxicity with acetaminophen kidney toxicity with NSAIDs, and we also want to determine how has the pain affected their quality of life. Are they able to maintain a full functioning life? Are they able to complete their activities of daily living? Or is this now creating another major barrier? After taking the medication, how would the patient rate their pain? After 30 minutes for parenteral administration or 60 minutes after oral administration? We always want to follow up, have that pain assessment, and make sure that our intervention has been effective. We're also going to be documenting that we've followed up and determined the patient's pain relief. We can also look at nonverbal cues to pain. Observe the patient for posture and behavior. Observe facial expressions. Listen for sounds made by the patient. Inspect the skin for color, temperature, moisture. Be looking for any rise in blood pressure and heart rate. Assess the respiratory rate and pattern. And also observe the pupillary sign and reaction to light. There's a wide variety of different pain scales you could use. Everything from the number rating scale, which is going to be far and away your most common. Though, keep in mind, you get into very young children, elderly adult, patients who are nonverbal. We start looking at things like the Wong Baker scale or the Flax scale as different ways for us to put an objective measurement on the subjective experience that is pain. Dealing with infants and children's in pain is going to be especially difficult because again they aren't able to verbalize their pain. They're not able to verbalize a lot of the descriptions to give us clues into how to treat it. Neonate responses to pain are global, evidenced by increased heart rate, hypertension, pallor, sweating, and even decreased oxygenation saturation. For young children, they have difficulty understanding the pain, but do have the basic ability to describe the pain and location. And finally, for older adults, although transmission and perception of pain may have slowed down in older people, pain is felt no differently than any other adult. Many older adults have a lifetime of experience in coping with pain, but pain is not an expected part of aging. And again, anytime a patient tells us we're in pain, we need to take that serious. That is that fifth vital sign. We never want any patient to be in pain, and it can be a very difficult one to treat as well. But anyway, that's all I got for this chapter. I'll see you in the next slides.